With this short talk on thoracic outlet syndrome. As the majority of you will know, thoracic outlet syndrome is a condition where the proximal vessels and nerves of the upper limb are compressed by the scalene triangle, the clavicle and the first rib, or the pectoralis minor muscle. And it produces an array of different symptoms with pain in the arm, the chest, neck, headaches. And it can be quite complex to diagnose, especially if the patient has had the condition for a number of years, as it is often missed by non-vascular experts. Classically in the literature, the symptoms are paresthesia, especially in the fingers. I find the fourth and fifth fingers, the paresthesia is most prominent because the lower trunk of the brachial plexus is often stretched over the first rib or the cervical rib. The neck pain is very common, shoulder pain, so they often come from the shoulder surgeons, headaches, migraines, supraclavicular pain, chest pain is quite common, shortness of breath. I've also seen patients with visual disturbance when the arm's elevated, and they've been to see the stroke physicians or the ophthalmologists. I've seen patients with Raynaud's and very varied conditions, muscle facial spasm, which has been mistaken as stroke. So these patients are quite difficult to pick up at times. So in the examination, I use typically Adson's maneuver, Roux test, upper limb tension test, and then Tunnell's test over the brachial plexus, the medial condyle, epicondyle of the elbow, and over the median nerve. And I will do basic shoulder examination. And the literature suggests that the symptoms are reproduced with the surrender position, the upper limb tension test, scalene muscle tenderness, pressure over the brachial plexus, neck rotational tilt, and increased sensation to light touch. So here we have a patient of mine who you can see has, in the surrender position after a minute or two, a white hand on the right side. And this patient has suffered from Raynaud's for many years and then started getting more hand weakness and pain and arm pain over recent years as he built himself a home gym and started exercising and building muscle in his shoulders and arms. And this is very common, as you know, in patients that are younger, in their 20s and 30s. They go to the gym, they build up the muscle, and they narrow the thoracic outlet space even more by enlarging the scalenus and subclavius muscles. And this patient here, when the arm was dependent, it reproduced his Raynaud's symptoms, which he'd had for many years. Another patient of mine had a year's history after a road traffic accident of a weak right arm with pins and needles in the arm and hand, pain, a cold hand, a weak hand, losing coordination. And I saw her and repeated some of the tests and found that she had a fractured first rib of a callus and a subclavian and axillary artery aneurysm which had embolized to the brachial artery. So she underwent a right first rib resection and repaired the subclavian artery aneurysm. I used the paraclavicular approach, which I'll explain in a bit. Excision of the aneurysm was carried out, and then a bovine patch repair of the vessel once the rib was removed, which gave me space to carry out the repair. the patient underwent a full recovery and fully regained function in the arm. We often see patients with cervical ribs with thoracic outlet syndrome, and you can see these ribs are easy to spot, but some cervical ribs can overlie the first rib and can be difficult to see. Some first ribs can look abnormal, and you can't tell whether they're a cervical rib or there's a prominent transverse process which has a band. And the way to tell is the transverse processes of the cervical spine point downwards. And if the rib comes off a transverse process which is pointing down, it's probably a cervical rib. You can get lateral views. I always get a chest x-ray and a cervical spine x-ray because the MRI scan and the CT scans can miss cervical ribs. So this patient underwent a left cervical rib and first rib resection. I always remove the first rib at the same time as the cervical rib, so I don't have to go back again 4 or 5 years later into a scarred area for recurrence. So this is the equipment that I use, and you can see here that here I've got written down the right-hand side here, the S retractors, which are very useful for protecting the brachial plexus and the artery and the vein when removing the rib. The rongeurs are used for cutting the rib very accurately and safely. I use bipolar diathermy below the platysma. I use a Howarth retractor, a periosteal elevator, as it has a one-sided sharp elevator so we don't damage the pleura or surrounding structures to clean the rib. McDonald elevator in order to get the pleura off the back of the rib, because using a finger will cause a breach in the pleura. A nice small file. Be careful with the file, that needs to have blunt round ends because that can also cause a breach in the pleura. And then Cocker's and Alice forceps for removing the rib. I use a paraclavicular incision. I've carried out about 80 or 90 of these rib resections using this approach. And this gives me full access to the supraclavicular space where I can carry out a full brachiolysis, remove any scar tissue, bands, aberrant vessels from the subclavian artery or vein. This is why they get a mixed picture of TOS, because if they have aberrant vessels running through the brachial plexus, which I've often found when the main vessel is occluded, when the arm is in the surrender position, then these aberrant vessels become engorged and then they compress the brachial plexus, giving them neurogenic symptoms. You can see here that the artery has been nicely freed up without having to dissect into the root of the neck where the phrenic nerve and the lymphatics and the jugular veins, etc. are, because this, in my view, is the danger area where a lot of the complications come from. So I transect the scalenus anterior by pulling the muscle fibers towards me, and I go through the fibers with bipolar diathermy. I can get to the rib easily through here, and then the front of the rib I access through the infraclavicular approach. So this is the clavicle here. You can see this is where the supraclavicular dissection was, and I make an incision through here. There's a nice ribbon of fat between the muscle planes of the pec major, and you can go through an avascular plane and come down onto the front of the rib. This is the posterior part of the rib. The brachial plexus has been separated, which gives me good access. And here, using the rongeurs and the S retractor protect the brachial plexus, and the rongeurs is facing away from the other part of the brachial plexus and the artery, I can cut through the rib very cleanly without damaging the pleura. And here, through the infraclavicular approach, this is the clavicle here, I can protect the vein with the S retractor, and I can cut through the front of the rib. I get my assistant to push down on the back of the rib, so it creates more space for cutting the front of the rib, so I can get a very medial cut without damaging the vein, so that the vein can have plenty of space after the operation, so you don't get venous compression recurrence. And here, removing the rib via the infraclavicular approach is much safer in my view, so we don't actually damage surrounding structures with the sharp rib. And you can see with the total rib resection approach using paraclavicular, we can remove large parts of the rib so that the brachial plexus, the artery and the vein is free from compression in the future, and this is important. I'll explain why. And this is the incision, which is closed with a 3-O-proline suture removed 3 weeks later. It's important to have this incision. Any straight incision over the clavicle can get hypertrophic. And you can see here we can remove large parts of rib via this approach. So here we have a patient that had arterial, venous and neurogenic TOS, presented with compartment syndrome, first on the left side, and he had fasciotomies on the left side and a first rib resection. And then 6 months later on the right side, while he was waiting for surgery, he ended up developing compartment syndrome on the right side, even though that was asymptomatic originally. And you can see here his fasciotomies, which were carried out by the plastic surgeons as an emergency at the local plastic centre. And he underwent a right first rib resection, and the fasciotomies have all nicely healed. And he returned to full function. So what are the lessons learned from my series of over 80 rib resections? Thoracic outlet syndrome is one of the most controversial diagnoses in clinical medicine. It is classically divided into arterial, venous and neurogenic. But in my view, it's never as simple as that. I have a series of over 80 patients. They're assessed with Likert scales and DASH questionnaire. I use ultrasound-guided scalene, steroid and local anaesthetic injections for diagnosing the neurogenic TOS in those patients with chronic regional pain syndrome or chronic pain. I use a paraclavicular approach for total first rib resection and brachiolysis. And pre- and post-operative physiotherapy of an upper limb physiotherapist is vitally important. Otherwise, they will get recurrence. It doesn't matter what surgery you do, if you don't carry on with the physiotherapy for years afterwards, the exercises are really important. They don't actually physically have to see the physiotherapy for years. They have to do the posture, the neural stretches, and the exercises. So in my series, you can see that 40% had a history of trauma, which was whiplash or worse trauma. 79% had a mixed picture of TOS. 0 patients had arterial TOS alone. 1 patient had venous TOS alone. And 20% had neurogenic TOS alone. And that is different from what the papers suggest. So these patients were assessed with Likert scales out of 10, and the median pain scores were 8, and the neurogenic scores 8, and the function was 30%. And 6 months after surgery, the pain scores were 2, neurogenic 1, and function was 90%. So what are the lessons learned from this series? Total rib resection offers a significant improvement in TOS symptoms, and I have 4 cases of recurrence, 8%, which is lower than in the literature, and I believe this is because I'm removing the whole of the rib. 0 patients had arterial TOS alone, So a good history is vital to get the diagnosis. 80% had a mixed TOS picture, and the paraclavicular approach allows total rib resection with safe access. So there's no blind cutting of the rib. You stay out of the root of the neck where the dangers are. And I use the scalene ultrasound-guided local anesthetic injections for diagnosis and steroid and local anesthetic injections for treatment of TOS, neurogenic TOS, with the help of the physiotherapist. So this is our referral pathway. As at the beginning, the patients were staying with various specialities and not being referred on. And then they would develop chronic pain, chronic TOS, which is harder to treat. So the patients come from the general practitioners, the orthopedic shoulder surgeons, the orthopedic spinal surgeons, emergency department for upper limb DVT or arm ischemia, and the physiotherapists. It's important to give lectures to these groups so that they know you're willing to accept these patients. Even if they haven't got TOS, they need a proper assessment. So we give them all the vascular assessments, dynamic duplex, X-rays, MRI, the C-spine, brachial plexus, and shoulder, if there's possible shoulder pathology, nerve conduction studies, and then they may go on to get an old-fashioned venogram or MRA or MRV. They may have to go and see specialists like cardiology if they're getting chest pain, etc. The vascular assessments are not foolproof. They may give you, again, a mixed picture. So I think it's important to carry out a total rib resection. So if there's no TOS, they go to the orthopedic team. If there's vascular TOS, they get a rib resection with physiotherapy. If there's neurogenic TOS, they get scalene injections. And if the symptoms are severe, they then go on to have a rib resection. Thank you for listening to my talk, and thank you for the invitation.
The question I wanted to ask was that have you used nerve stimulators when you are dissecting in that area? To both of you.
Well, I'll answer first if that's all right. So I don't use nerve stimulators. I use bipolar diathermy, and I've not had any nerve injuries at all. And the bipolar tells me when I'm close to the nerve, because the patient's arm will start trying to hit me in the stomach while I'm operating. So as you get near to the brachial plexus, the arm will flinch a little bit, but it's bipolar on a low level. It doesn't cause any damage. Not had any nerve injury. I don't use nerve blocks from the anaesthetist beforehand, because if there is any nerve damage, I know the nerve damage is down to me and not them. And afterwards, what we do is we fill the space with 0.25% bupivacaine with adrenaline, 20 mils, into the space, and we leave a ready vac drain in, which is not opened until the patient is in recovery. And this gives them a full block for 24 hours. And it's better than any ultrasound-guided block as far as I can see from my experience. So we don't use nerve stimulators.
Yeah, there's another question. Yeah.
Thank you. Thank you, Howard and Waqas. I just want to ask that about 20% of the thoracic outlet obstructions are non-osseous, and maybe because of the fibrous bands or the hypertrophic muscles or the muscle hypertrophy. So, because CT scan or maybe the X-ray will only highlight the bony problems. So, if the index of suspicion is very high, then how you go about evaluating these non-bony causes of thoracic outlet obstruction? Thank you.
You want me to say anything? I have some experience with this, or Waqas can go first.
So can you repeat your question, please, in a short?
So in some of the patient, the causes of thoracic outlet obstruction is not because of the cervical rib or the first rib, but because of the soft tissues, fibrous bands, tendon insertions, or hypertrophic muscles. So what is your plan, or what are your thoughts about how you evaluate such non-bony causes of thoracic outlet obstruction? Do you get my point?
Yeah, I'm happy to answer if you want, Zia.
Yeah, sure. That is very important question. Yeah.
So it is an important question, and this you get this experience as you get more experienced in the thoracic ribs treatment. So essentially, when you're examining and taking the history, it's quite important to assess them in the surrender position with the face forwards, and then turn to one side, because if the pulse is present when the head is forwards and then when the head is turned away, then that may indicate it's the scalenus anterior, which is compressing the artery. But often the artery and the nerves, as you know, are very close together, and they'll get a mixed picture of symptoms. And when I feel that there's no evidence of vascular compression on the duplex scans and other scans, then I use an ultrasound guided local anesthetic injection in the clinic. Wait 20 minutes. And I just inject into the scalene anterior and into the scalenus medius. It's very easy to do. I use a blue needle. I use 0.25 Chiracaine, so I don't give them a motor block. And a blue needle, a small blue needle, 23 gauge, will not give a pneumothorax if you're learning the technique. And it will just reach the muscles, and you can see them very clearly, and you inject those. And if the symptoms go, then it indicates it's to do with the scalene triangle. And that's what helps me to diagnose which ones are which. But the problem is, if you just do scalenectomies, the nerve injury rate is quite high, because you have to remove quite large segments of muscle, and the recurrence rate is high. And I say to my patients, if they get recurrence, the rib is gone, the whole of the rib is gone, there's no need to go back in. The only remaining treatments are physiotherapy and posture exercises.